Good evening, everyone. I hope you can see me and hear me. Uh, a very warm welcome to the very popular and in-demand BOFAS Master Techniques, and this is episode number 17. So today I am excited that we have a topic which a lot of us, and especially youngsters, are interested in: minimum invasive surgery. And we have two very good and internationally renowned surgeons who are going to share their tips and tricks with us. Before I go any further and before I forget, I would like to first of all thank the BOFAS IT committee, who is always behind the scenes and has done really an amazing job. And without the support of IT committee, this sort of online webinar series would not have been possible. And a special thanks to May, who is doing her last master technique. She has been doing this with me for a long, long time. And together, I think we have done about 14 master techniques so far. Also, a couple of housekeeping announcements. Please put your questions in the Q&A rather than chat. And once the webinar is finished, you'll be automatically taken to a link for the feedback. And once you've done the feedback, you will get the certificate. And do not shy to put your questions in the Q&A session. So the theme of this evening is that we have divided. So we are going to talk about MIS around ankle and hindfoot. And we will do the bony procedures first. And Peter Lam, I'm really honored that Peter has decided all the way from Australia. It's 7 o'clock, I believe, in Sydney, where he is. And he will be with us in a second. And he will take us through the tips, tricks, and practical technique for calcaneal osteotomies. And after that, we'll do the soft tissue bit where I'll invite Robbie to do that. So Peter, if you don't mind, can I ask you to... So Peter does not need an introduction. He's a world authority on minimum invasive surgery. He has published widely and lectured around the world. He'll be joining us in BOFAS in Glasgow in 2-3 weeks' time. And I'm really looking forward to hear from Peter about his own tips and tricks. Thank you, Peter.
Thank you very much, Maneesh, for inviting me to speak at this Masters Technique webinar. I've got my screen there. Can you see that? Great. And so I've been asked to speak on the techniques for MIS calcaneal osteotomy. These are my disclosures. And what I've been asked to do is talk about the surgical technique for the calcaneal slide osteotomy for treatment of hindfoot varus and valgus deformities, and on the technique for Zadak dorsal closing wedge osteotomy for the management of painful insertional Achilles tendinopathy. I like to place my position in a floppy lateral position with the foot on a bone foam. I personally prefer tourniquets, but I think tourniquets are a surgeon preference, whether you like it or not. And the reason I use the bone foam is that it raises the heel slightly upwards, and also I can place the foot anterior to a bone foam, giving me a true lateral position of the calcaneus. And for me, this is important because when I place the burr, I can place it perpendicular to the ground, and I know that I'm cutting transversely through the calcaneus. Whereas if the foot is not sitting in a true lateral position, then you have to then work out what direction to aim the burr so that it's cutting perpendicular to the calcaneus. And in this floppy lateral position, I can externally rotate the leg easily intraoperatively. And so in a patient with cavo-varus deformity, I can perform a dorsiflexion closing wedge osteotomy of the first metatarsal. And at the same time, I can get the anesthetist to pull the drape And so that way I can externally rotate the right leg to get the medial side to do tendon transfer in a patient with progressive collapsing flat foot deformity. And so with the procedure, I use the guide wire to mark out my line of the osteotomy. I like it anterior to the tubercle and towards the plantar tubercle. Once I've located this line, I draw a skin marking. And once this is done, I place the guide wire to the center of the calcaneus. And you have to remember the center of the calcaneus is not from the skin, but from where the fat pad joins to the calcaneus and the superior border of the calcaneus. I like the wire to exit just inferior to the Achilles insertion, perpendicular to my osteotomy line. So I'll mark this out and I'll also confirm that on the II as shown here. I make my incision at the intersection of these two lines. Once this is done, I use a periosteal elevator to elevate the soft tissue along the line of my osteotomy so that the burr does not get caught in the soft tissue. And then I strip using periosteal elevator and strip along that line inferiorly down to the fat pad. Once this is done, I insert the burr through that incision perpendicular to the ground, so it's perpendicular to the calcaneus. And then I use this pulsing maneuver to feel the far cortex. Once I feel the far cortex, I place my left hand underneath the foot so that I can feel the burr coming through the far cortex. So this way it allows me feedback to stop the burr as soon as I go through. Once this is done, you can see that I'm at right at the hilt of the osteotomy. This is the image intraoperatively. I'm going to extend the burr so that it gives me more leeway when I cut through the far cortex of the bone. Once this is done, I go through the same hold I've made. I cut the bone through the medullary part of the calcaneus, aiming towards the superior border of the calcaneus, following the line that I've drawn on the skin. And I get an eye picture, make sure I'm cutting along the line that I had previously set. And I aim, and then you'll perforate along the superior medial border of the calcaneus. So that's because of the direction that the burr has to go. Once this is done, I cut the knee cortex, and you can see I used my left index finger to feel the burr as it's about to come through the knee cortex. So it provides me with feedback so I can stop as soon as I'm through the knee cortex. Once this is done, I place the burr back along my original line. So that's at the superior medial aspect of the calcaneus. And I cut the far cortex. And it's important to note that when you cut the far cortex, and I'm about to cut through a knee cortex. And when you have a young patient like this guy who's in his early 40s, the bone's going to be hard. Important, and so here, when you cut through the far cortex, it's important that you draw the burr as you cut, because if you follow that line, then you may cut the medial tissue. And you can see as I cut along there, I've withdrawn the burr slightly. I go back to where I've cut through the cortex. I slowly cut towards the holder I've drilled initially. And so this way I cut the calcaneus in 4 quadrants. And so once I've cut down to the hole, then I aim the burr. So I check the X-ray. You can see the superior half of the calcaneus has been cut. And then I place the burr through the same hole and I aim along the skin marking until I perforate through the plantar medial aspect of the calcaneus. And once I've gone through, I'm just about to go through now, I get an X-ray just to make sure I'm in the right line. And once that's confirmed, I cut the knee cortex and once I cut through the knee cortex, I use my thumb of my left hand to feel that it's coming through the cortex. Once this is done, then I put the burr back to the original entry point, and I cut the far cortex using the same technique as I did cutting through the far cortex of the superior calcaneus. So this is the fourth quadrant. And I aim to cut towards the initial holder I made with the burr. Once I've completed what I think I've completed the osteotomy, I insert a 1 centimeter osteotome. I like to use a wooden handle osteotome so I can use the wooden handle to twist the osteotome to separate the osteotomy. And so I've just gone through towards the my original hole that I made with the burr at the start of the procedure. And so I use the osteotome to just tweak it to break the osteotomy. Once this is done, I insert a laminar spreader, a non-tooth laminar spreader, to spread the superior half of the osteotomy, just like you would do when you do an open calcaneal osteotomy. And this will separate the fragment quite nicely. And I don't normally x-ray it, but I'll do an x-ray just to show the separation. And then I flip the osteotomies, and then I insert it through the inferior half, and I spread that. Once this is done, the fragment is going to be very loose because you had already cut about 4 millimeters of bone with a 3 millimeter burr. And so you can see here, the osteotomy is quite mobile. And so it's generally very easy to shift it, both laterally, as in this patient with Hindfoot varus, or medially in a patient with a valgus deformity. And so once this is done, I insert the 2 guide wires for the fixation. And the superior wire I insert at the inferior to the Achilles insertion. I aim it just slightly dorsally, and the inferior wire I aim in line with my skin marking so that the wires are slightly divergent. Once I've inserted a wire, I reduce the osteotomy, and this one is slightly valgus. I dorsiflex the ankle to maintain that displacement, and the wires advance into the distal fragment. I take an X-ray picture showing the wire placement inferior to the Achilles insertion and slightly divergent. I measured the screw length. I drilled the knee cortex. I inserted 2 screws, and this is the final appearance. And then I do an axial X-ray. And in the case of, and so you can see the hindfoot varus is reduced. And you can see normally for hindfoot varus, there is not a lot of lateral displacement, but there's also tilting of the fragment, which I'll describe in subsequent slides. So I irrigate the portal, and I close with 4 repeat sutures for both the burr portal and the screw placement portal. And so with this technique, because you remove about 4 millimeters of bone, it can easily tilt the fragment as well as displace it, unlike when you do an open calcaneal osteotomy. So you have to take care not to overcorrect, because if you displace a lot and tilt, sometimes you can overcorrect. And so you have to be very careful with this procedure, not to overcorrect. And these are 2 case examples of patients with progressive collapsing flat foot deformity. You can see again, there's medial displacement and tilt, providing additional correction to patients for more severe deformity. And this is an example of a patient where I've done a cotton osteotomy at the same time. And so for patients with a cavo-varus deformity, I use a 3 millimeter burr to perform a dorsal closing wedge osteotomy of the calcaneus. I fix that with a 4 millimeter screw. And this is the pre-op and the final post-op X-ray. Now, what to avoid? And so in terms of the osteotomy, it's important not to place the osteotomy too anterior. And also in a patient with significant gastrocnemius tightness, I would recommend to do a gastroc release prior to the calcaneal osteotomy. Otherwise, the fragment can displace superiorly, and also to not make the osteotomy vertical as in this situation. So in this case, the patient can complain of two problems. One is plantar heel pain from this plantar spike and posterior impingement from the superiorly displaced heel fragment. And this is the CT appearance showing the posterior impingement and a 3D reconstruction showing the spike. So now I'd like to move on to the surgical technique for performing a percutaneous ZADAC dorsal closing wedge osteotomy. And so there are challenges to performing a percutaneous wedge osteotomy. And Zayed and Pereira first published the percutaneous technique in their review paper in Foot and Ankle Clinics in 2016. And so they used 2K wires to help guide the osteotomy. And they also made the incision centrally, just like with a calcaneal slide. When you use two guide wires to cut the osteotomy, it's often easier to make the first cut, but it's often hard to make the second osteotomy cut in a nice vertical manner, like the first cut. And what's the problem with placing the osteotomy centrally is that when you direct the burr inferiorly, there's a significant risk of perforating the plantar cortex. And if you perforate the plantar cortex, then this is no longer a closing wedge osteotomy, and the osteotomy configuration is going to be unstable. So you have to really be careful to preserve that plantar hinge. And Kaplan and his colleagues published this technique paper in Foot and Ankle International 2 years ago. And they also described making the incision centrally as shown here, like with a calcaneal slide osteotomy. And they describe using two guide wires to cut the dorsal closing wedge. And rather than removing the fragment as one piece, which is often very difficult because of the soft tissue attachment along the medial aspect of the wedge, they describe cutting the wedge out in segments to facilitate that. And you can see here the first cut is straight, but the second cut is very hard to make that a nice straight cut. And they close the osteotomy by dorsiflexing the ankle as shown here. And the osteotomy is closed with, stabilized with two cannulated screws. One of the problems with the osteotomies, as you can see here in this case, you can make the first cut nice and straight, but the second cut can be difficult to make straight. And so you can see that the anterior cut is a chevron cut. And one of the problems with the chevron cut in this situation is when you close the osteotomy, to preserve the plantar hinge, you can't fully close the superior part of the osteotomy. So even though it looks like at the time of the osteotomy, the surgeon has done a nice
Have we lost Peter?
dramatic relief. And so it's like a straight cut. And the other problem is this situation whereby the plantar hinge has been compromised. And so in this situation, where the plantar hinge has been compromised, it means that the osteotomy is not stable. So when the patient weight bears on it, it displaces, and this can be a very difficult problem to salvage. And so it is most important to preserve the plantar hinge with this procedure. And if you compromise the plantar hinge, you have to make sure the patient's non-weight bearing for 6 weeks to allow some stabilization of the osteotomy. And so as a result, I've developed this alternate novel technique that's been developed by Enovis. And so I use a 3 and 5.5 and 8 millimeter burr to make my osteotomy. So I place the patient in a similar position as in for a calcaneal slide osteotomy in a lateral position with the bone foam, and the foot is placed anteriorly so I can get true lateral x-ray of the calcaneus. I mark out the line of my osteotomy. I like the apex to be at or slightly posterior to a plantar tubercle. But in a patient with a cavus foot, it might be just slightly anterior to a plantar tubercle. I mark out the apex of my osteotomy, and I also mark out the line of my superior screw. And I make my skin incision at the junction of the osteotomy and the apex of the of my osteotomy. And I use a periosteal elevator to elevate the soft tissue along the line of my osteotomy. And I use a 3 mm burr to cut the medial cortex. And you can see my left hand on the medial side feeling the burr as it comes through the far cortex. And I take an X-ray just to make sure the osteotomy hole is at the apex where I want it to be. And I cut the knee cortex. And so this is rather than cutting 4 quadrants, I cut it in 2 halves. So I insert the burr following the line of my skin marking. I get an X-ray to confirm that, and I perforate through the superior medial cortex, and I cut the medial cortex. Sorry, I cut the knee cortex, and I put the burr in to cut the far cortex as shown here. Once this is done, I insert a 5.5 mm burr. I repeat this process, cutting the knee cortex and the far cortex along the same track. Then I insert an 8 mm burr. And with the 5.5 and 8 mm burr, I use this on the drill rather than with the irrigated burr system, because what we found is that if we use a drill system, it creates less heat than with the normal burr system for MIS surgery. And so with the 8 mm burr, I know that I've removed 10 mm of bone because there's often a 1 mm gap between the burr and the osteotomy. So this is showing the progressively increasing tunnel that I've made. I dorsiflex the ankle and knee, closing the osteotomy. I insert the proximal wire in line with the skin marking and slightly divergent inferior wire. I like my screws to be inserted inferior to the Achilles insertion. And so I insert the 2 screws as shown. And so this is the preoperative and 6-week postoperative X-ray showing the early bone healing along the tunnel. And this is the 6-week post-op CT scan showing early healing along that tunnel. And so generally the healing is very good despite removing that tunnel of bone. And so this shows post-operatively the closure of the osteotomy. And generally with this system, you'll remove at least 10 mm of bone. And it is important when you use the 2-wire technique to remove the wedge that you measure the length of the superior calcaneus prior to the surgery and make sure that you cut enough intraoperatively. And the reason is that when you use a 2-wire technique, you can't really measure what size wedge you're taking, so you're estimating. And so generally what I've found is that if you do measure superior border, you have to remove about 1/3 of the superior border of the calcaneus in order to remove 10 mm of bone. And so sometimes that can look very wide. And so this is a patient of mine who had the open takedown procedure 5 years prior to ZADAC operation. And I think with the open takedown procedure, what you're doing is to reinsert the Achilles insertion slightly anterior and superiorly to offload the Achilles insertion. And so ZADAC does the same thing by inserting, by making the Achilles insertion go slightly superior and anterior to offload the insertion to address the painful insertional tendinopathy. Thank you.
Thank you so much, Peter, for a very wonderful presentation, very visual and very, very practical, which actually the audience wanted. What we'll do is we'll let Robbie come and we'll do a combined discussion. We've already got a few questions for you, but we'll wait to Robbie to finish his presentation. So Robbie Ray, as you know, is a very established orthopedic foot and ankle surgeon, again, MIS guru in UK, who I believe was trained by Peter Lam in Sydney some few years back, and then he went on to do fellowship in Canada as well. And he's an excellent teacher, really, really nice guy. Lots of people have gone to Robbie, and he's actually, along with David Gordon and some others, making MIS popular in UK. But today, he's not going to talk about any bony procedure. As I said earlier, we have invited Robbie for one of his newer talks. So he's going to talk about ligaments around the ankle and how he uses endoscopy or minimum invasive techniques to do ligament reconstruction. Over to you, Robbie.
Okay, good evening, everyone. Maneesh, thank you for the introduction. You can hear me okay?
Yeah.
Perfect. So yes, so Maneesh asked me to talk about soft tissue MIS techniques. I said, look, if Peter's doing bones, how about I talk about arthroscopic ligament reconstruction, as the arthroscopy is also MIS in my mind. So I've got some disclosures, nothing pertinent to this today. So today I'm going to talk to you about ankle sprains and arthroscopic ligament repairs. And as we all know, ankle sprains are some of the most common injuries that we see in the UK. It's probably the most common injury. And this is Neymar, you saw on his left ankle having multiple bad sprains. So I think many of us have experienced ankle sprains and they're extremely common. So first thing is, should we be repairing ankle sprains regularly? Well, if we look at the Cochrane database, this is quite outdated now, but it said there was no evidence to say that surgery gave better results. But when I was training, I came across a really interesting paper from Nick Van Dyke. This was a prospective trial where they looked at the outcomes of ankle ligament repairs versus conservative management. And the outcome to me was quite clear. It said that operative treatment led to better results, a short and long-term follow-up. But that wasn't the conclusion they gave from this paper. Like many papers at the time, they said, despite statistically significant better results, they were questioning whether operations are a good idea. They said delayed operations also give good results compared to acute repairs. And they suggested that if we were to repair every ankle sprain, it would put too much of a burden on the health service. So they were saying we shouldn't repair ankle ligaments. However, there's been a lot of work on this since then, and there's a large consensus statement which showed that not only do they may be costly to repair them, but what about the costs of the ankle sprains themselves? Bad ankle sprains take people out of work, they take them out of sports for extended periods of time, require lots of rehabilitation. So there's actually a lot of costs to ankle injuries themselves. I think still today we can't be clear about whether we should be repairing all ankle ligament sprains or not, but this is a technical talk. So I'm going to say that we should be repairing more than we do. I'm going to talk more about the technical side of things. So when I published a current concepts on this a couple of years ago, we looked at the different repair techniques, and we found that the modified Brostrom procedure was still the gold standard in most people's minds. However, when we looked carefully at the results that were coming out, they showed that arthroscopic results may have had better results in the short term and equivalent results in the long term for recovery and even for sports. So it's possibly something that people should be thinking about. How I got into arthroscopic ligaments was when I trained with Peter, as Maneesh said, seems like many years ago now. I learned MIS and came across BOFAS, which is a big organization now. At the time, it was still fairly fledgling. And I wanted to go to the meeting to see this man, Joe Vernois, talk about MIS. But I actually came across Jordi Vega. And he had a breakfast meeting and he was talking about his new techniques, extremely new at the time, which was an all-inside arthroscopic repair. It's something I hadn't heard much about, and also microinstability. So this was an ESCA paper that came out recently. You may have not seen it, but it's definitely seen you. And it's the concept that with ATFL injuries, which is part of the lateral ligaments, people get this syndrome where they get pain, vague feelings of the ankle not being strong, but not frank mechanical instability. And there's probably a lot more of this than we consider the patients that we see. He published this paper with a 3-portal all-inside repair, And in 2019, I went to the first advanced arthroscopy course so I could learn how to do these techniques. So if we want to do arthroscopic ligament repairs, and we have to know the anatomy. So when we start looking at the anatomy, we can see that the lateral ligaments, they're more complex than we thought at first. If we look at numbers 5 and 6, that's the ATFL. Number 5 will be the intra-articular component of the anterior talofibular ligament. Number 6 is the extra-articular component. 10 is the CFL, the calcaneofibular ligament. And behind this, there's also the PTFL. Now, we all know the calcaneofibular ligament is a stronger ligament. And when we first think of them, we think of them as discrete structures. But as we look at different anatomical detections, we can see that they're all intertwined and interconnected. And if we dissect them right down, we can see that looking at number 1, which is the ATFL, and number 4, which is the PTFL, we can see that they're all connected and interconnected sling. So perhaps by repairing the front ligaments, we can tighten up all the ligaments if they're all connected. If we're going to do these repairs, it's important to have an idea of what the normal anatomy looks like, as well as the pathoanatomy. So in this first video, I'm going to show you just what a normal lateral gutter looks like. So we're starting with the talus here, and this is the AITFL ligament. So as we follow that down, we can see the hammock. That hammock is the ATFL, and we can see the fibula peeking out from behind. In a normal situation, it's difficult to actually get into that gutter and see it properly because it's all intact. Next thing, again, this is starting a bit higher up, tibia and talus. This is the early pathology. So as we look at the early pathology, I'm shaving the thick AITFL here to come down into the gutter. We can see the gutter is much more open. And this is only a mild instability. So we can just see that there's gapping underneath the fibula. So the ATFL is still there, fairly normal, but it's loose and it's not attached properly. And as we get into the more severe situations, we get into the gutter, we find a lot of synovitis. The bone's pretty much bare there, and we can see underneath that the ATFL is much less normal looking, red, thickened, synovitic. And you can see that the structure is nowhere near as normal as the preceding images. So now let's talk about how we're going to repair that ligament. To repair it, I'm going to show you a pictorial diagram, then I'll show you a video. So the picture works like this. The red is the ATFL, the green circle is the fibula, and the blue triangle is the corner of the talus. Again, red is the ATFL. So starting at the top left image, the green circle is the distal fibula, blue triangle is talus, and that's the ATFL crossing here. Although this looks fairly normal in that first image, as I pull on it with the arthroscopic probe in the second image, you can see that it's unstable, it's coming away. We can see right underneath that front tip of the fibula. So from that point, once I know it's unstable, coming on to the third image, I'll grasp it with a jaw-assisted device, and I'll loop a thread around it and make a luggage tag type knot that you can see on that. That's the loop, and you can see the knot here. And then finally, you can see in the bottom right image as I've tightened it all up. And now you can see it's completely tight as opposed to the gap here. So let's talk about the technical aspect of doing the operation. So first thing I do is an anterior drawer test. And we can see a fair bit of instability in the ankle. That's how I do an anterior drawer to double-handed grip. The technique here, we don't use any distraction. It's a dorsiflexion technique. As I was learning how to do this, you may have noticed I was getting a bit fatter, and it's because you need a decent belly to do this operation. It's getting harder for me now as I'm losing a bit of weight. You can see that if you position the ankle just off the end of the bed, you can get a decent amount of dorsiflexion. The reason we dorsiflex is this opens up the anterior space, and traction actually tightens the ligaments. You can't see them properly. So I do all my ankle arthroscopy using simple European dorsiflexion technique. I mark out the tibant tendon and I mark out the SPN. The lateral incision is always close to the SPN, but I like to know roughly where it is. The two marks I've made there, the one on the medial side here is the where you think you'd make your entry portal in plantarflexion. It's on the medial side of the tibant, and this mark here is on the lateral side of the tibant. But when we dorsiflex the ankle, the tibant actually moves significantly laterally. So my incision actually ends up pretty much where that cross is marked, but that'll still be on the medial side of the tib ant. So you see here, I've got my thumb medial to the tib ant, but as I dorsiflex, the tib ant actually shifts, and that's where my thumb is now, is still on the tib ant. I'm pushing it out of the way, and my incision will be pretty much on that dot where it starts in plantar flexion. So always come medial to protect the bundle, but that's where you'll see it. So this is the technique for arthroscopic lateral ligament repair in brief. So the first thing is to clear the hypertrophic AITFL. That shows you where the ATFL should attach, which is just at the base there. You can assess the tear and see that it's a bit unstable. Then I can clear that base, drill out a hole. It's important to drill that hole really low because then you get more anatomical repair, less stiffness. Coming with my jaw-assisted device, grasp it with a suture, and then tighten that suture up, making a nice luggage tag, which gets a really good grip on the ligament. And then in this case here, I'm using a swivel lock anchor, which is screwed in under tension. And you can see that ligament is now tightly opposed. So one thing Peter mentioned to me when we discussed this was he had concerns about how much strength this would have for grasping this small piece of tissue. So this is a slightly newer technique, but I've grabbed that ligament, and you can see I'm pulling it. I'm pulling the ligament quite firmly, and what that looks like from the outside is like this. So this is just me holding the ligament, and you can see I'm lifting that ligament off the bed, the whole ankle off the bed on that ligament. So it's actually a very strong grip that you get. If it tears out, it's not strong enough for you to do something else. So a couple of years ago, we looked at my 12-month results. It's published in Foot and Ankle Surgery, and we found significant improvements in all of the standard measures that we were using. We had 2 patients with SPN paresthesia that settled with time, and the main thing that people complained about was stiffness with a simple repair. It was just something when we asked them, they said they felt stiffer than before, but they were still happy than before. Okay. So future directions. I'm interested in improving my technique and getting a stronger repair. As I do more athletes and athletic individuals, they need a really good repair. So the first thing is, how can we improve the tensioning? Because one of the issues I have is that with an assistant, sometimes I can't get the anchor tension so well. So with newer technology now, here's a different case. Again, you can see the injury there, debridement of that area, nice low drill point. Again, grasping my repair. And with different technology, this thing's called a Footprint Mini. With the newer technology, this anchor is actually, it's a post-insertion tensioning anchor. So once it's inserted using a mechanism in the anchor, you can then tension it further. So you see here as the thread will move now, and it tightens up beyond. I can tighten and loosen my tension so I can get anatomical tension on it. Generally, with a soft tissue repair, I want maximal tension. And this way, I can now reliably, in every case, and I never get into a situation where I've docked my anchor and it's a little bit loose, and it leaves me in the situation where I've got to think, do I put another anchor in? So in that case, this was my pre-op drawer, and this is the post-op drawer. I'm pulling just as hard, I promise you. Might not look like it. So then, when it comes to augmentation, we did a study on suture tape augmentation to see if we felt it was more, if we should be doing this regularly, because I started doing it regularly when I started as a consultant. And really, it seemed like it's hitting a nut with a hammer, because in most systematic reviews are still showing similar outcomes in repair and suture tape augmentation. But in obese patients, in poor ligament cases, perhaps in the athletic individuals, the jury's still out. We should be doing suture tape augmentation, and you can do this arthroscopically as well. So this is a cadaver. So I just did this yesterday for you guys. So the repair has been done here. You can see that in the bottom left corner. And once you've done your repair, you making you clear a footprint on your talus. It's got to be fairly anterior and fairly low to be in the right place. And I like to use knotless anchors. So I'll dock a knotless anchor primarily into the talus or drill it. You can see there's the white passing suture and the blue repair suture, and another knotless fiber tack into the fibula. I'll then cross the repair threads subcutaneously, so act like a bit like a ripstop mechanism, and then in plantarflexion I'll tighten them. I want to tighten in plantarflexion so that it doesn't over tighten, and you can see I've got pretty good tension on that repair. So there's a lot of work to be done on arthroscopic augmentation, where the perfect docking site is, how to reach it. Can we be certain we're safe for the nerve? We dissected the specimen afterwards. The nerve was well anterior to that repair, and that's one of our plans, to do some more studies on that. So moving on to the medial side, as I started doing more arthroscopic repairs, I realized that it's quite straightforward to come onto the medial side and look at the deltoid. This is what a normal deltoid should look like. So as you clear some of that fibrofatty tissue, you come onto the medial malleolus, and you can see those kind of sharpie fibers attaching the ligament onto the bone. It's all quite stable. There's a thick band there attached onto the bone. There's no way to get around it. The base is always bald. That's normal for the anterior medial malleolus not to have soft tissue, but the rest of it you can see is firmly attached and it's not giving way. But the more of these you do, you see these sort of lesions. You come onto that medial side and you can see that things start to peel off. It's not well attached. Very different to that first case. So that you can get in between that white stuff, and you can see it's just sort of possibly healed back on very loosely. Nothing like the first case. And what are we actually looking at there? It's these anterior ligaments. Definitely not the deep deltoid, but this sleeve of tissues with the talonavicular and the spring. These are all the things that attach onto the front of the malleolus. And as we can see here again, A, B, C, D, and D are all one structure. E, the deep deltoid, is quite posterior and not something that you'll be able to get at with these arthroscopic repair techniques. So Jordi Vega, again, they published their all inside lateral and medial repair. And this was really helpful for me when I was starting out, along with my friend Francesca Malagalada, as it gave me an idea of this anatomy that I'm describing to you just now, exactly what I should be looking at arthroscopically and what normal should look like. And they described what the lesions would look like, kind of like what I just showed you guys, what normal should look like, what abnormal should look like. And they also proved, Mickey Dalmal-Pastor, with his dissections, that you can repair these exact structures through the arthroscope, because sometimes you're not certain. And the good anatomist actually prepare the specimens after and show you what you can repair. So again, I'll start with the pictorial essay. The image on the top right is from Mickey Dalmal's paper. These are my arthroscopic images. So that's the medial malleolus. That's the medial talus. And this is the deltoid. You can see that it's peeling apart. So this is where I've made my insertion hole. I've grabbed it with a thread and now I've repaired it. And then you can see that it's tight. So this is what it looks like in practice in a sports situation. So you've done your lateral ligament, you come medially and you can see that this stuff's not, it's all peeled away, it's laminated, it's not structurally strong. Again, taking a jaw assisted suture grabbing device, grab the ligament, make a luggage tag and repair it back onto the bone under good tension. Again, pulling all those structures back up, giving good stability. We published our results on this. These were fairly early results. We probably have to publish a more detailed paper now. But again, the results were as good as our lateral ligaments, but not proving that it's necessary, just proving that it works. What about in a trauma situation? If you look at the picture on the left, you can see there's a large medial clear space. However, on the right, because of the medial malleolar fracture, there isn't. The medial malleus is still next to the talus. So this one on the left here is clearly going to be a deltoid injury. And one thing that a lot of us foot and ankle surgeons are talking about a lot is, should we be repairing this? And with arthroscopic techniques, I feel yes, because I always do a trauma scope to clear the ankle. At the same time, I think it's worth doing a deltoid repair, which I can show you. The conclusion of modern papers is possible we should really be considering these injuries, even though there's not a lot of evidence there, because there is an incidence of medial pain, flat foot, other sort of stuff if it's not repaired. So this is the video showing how we do that in a trauma situation. So here it's dead clear, if it wasn't in my other cases, that the deltoid is severely damaged. You can see here that there's infolding of tissue into the medial clear space. You can see the huge amount of damage all around the medial side of the medial malleolus. As I put the probe around, you can see that there's no stability there at all. I'm just using my RF to probe that area and clear any remaining soft tissue, but it's not really a lot of work being done. So again, I try and come really deep here and grab and pull all that superficial deltoid up from the base. I like to use knotless anchors in trauma, again, because I can get a bit more better tensioning. It's the same ones I showed you for the internal brace. Pull that passing thread through. And as that passing thread comes through, you'll see it starts to tighten up. And as it tightens up, you can suddenly see that there's a bit more normality to that ligamentous structure. I'll then do the same again, slightly higher up. Grab the ligament, pass this knotless anchor in, shuttle it through. And you can see here now that that's quite a solid repair, strong repair of that structure, completely bedded down. And when you do this, you can see that any medial opening closes up. So again, it takes a bit of time, but you can get very good repair. So thanks for listening. So in conclusion, arthroscopic anatomical repairs on both the lateral and medial sides are technically feasible. They've shown good results, but these have been from clinical series and generally from surgeons who are quite expert. More studies are needed to ascertain if augmentation is required in which patient populations, and also to give us a more scientific technique to augmentation. Medial repair is possible with instability. It's got good results, but when is it needed? And it's the same in trauma. It adds time. It turns it into quite a high technical skilled procedure that you need to be a specifically trained surgeon to do. Is it necessary and does it help? So thanks very much, everyone, for listening.
Thank you so much, Robbie, for an excellent talk. Lots of beautiful videos, illustrations to make your points. I think it's you conveyed your messages. I'm pretty sure people have liked. They've already said that they've liked it. So can we have Peter as well so that we can begin some discussion? Hi, Peter.
Yes.
So Peter, there are questions directed to you to start with. So the first question is, where do you aim your apex of the ZX to be in the relation with the plantar fascia?
I'd like to aim the apex at or just posterior to plantar fascia origin. If they've got cavus foot, sometimes I'll make it slightly anterior. But the problem is that if you make it too anterior, you actually tension the plantar fascia, and so you can get plantar fasciitis post-surgery. The other issue is that sometimes you get a plantar heel spur. You get plantar heel spur, you make the apex anterior. As you close the osteotomy, you'll make the plantar heel spur go plantar and make it symptomatic. So if you do ever see a patient with plantar heel spur, you have to make the apex posterior to that so that you don't make the spur go plantarwards, if that makes sense.
It does make sense. Thank you. The next question is, and there are few, so I'll just combine them together. So lots of people have asked, do you remove the Haglund's bump routinely?
No, I don't remove the Haglund's bump. And the reason for that is that you've got a Haglund's bump. If you do a closing wedge, it actually brings that forwards. And so basically removes the Haglund's in a way. And so when you do a closing wedge osteotomy, the Haglund's bump will move anterior. So there's no need to remove the bump. In terms of the Achilles insertion, I leave the spur in situ because when you move when you close the osteotomy, you'll bring the spur forwards. And so they usually don't have much of a bump. And what I tend to do is that if they do have a big spur posteriorly, I remove a bigger wedge. And so when they have a big spur, I generally remove 12 to 13 millimeter dorsal closing wedge, which if they don't have as big a spur, I'll tend to remove about 10 millimeter wedge, because I think they stick out more. You have to bring it forwards to offload the Achilles tendon insertion.
So just the philosophy of this osteotomy is that you are bringing the Achilles anteriorly. Do you see, therefore, that if you've not touched the spur goes away with time, sequentially, if you follow them, because there's not much tension, you've reduced the tension?
No, they don't actually go away. In fact, I think over time they do get slightly larger. We're doing our longer term follow-up review, and at 12 months, the spur are probably the same size or sometimes slightly larger. So, but the patient's not symptomatic. And I think when I was doing the open takedown procedure, if you follow them a few years down the track, oftentimes they do get recurrence of the spur, even though the open procedure, the patients are still asymptomatic, but spurs do come back. Because I don't think you really change the anatomy of the Achilles degeneration. So the spurs are still there, but for some reason they're not symptomatic with both the takedown and the Zadok procedure.
Thank you. There's another question about why you use divergent screw. Is it to get more purchase, more stability?
With all screw fixation, I tend to go either parallel or divergent. I just don't do convergent. And so you can do parallel or divergent. I don't think it makes much of a difference in this situation. And in terms of weight bearing, I let them weight bear as tolerated after 2 weeks. So the non-weight bearing at backstep for 2 weeks, then they weight bear in a boot for 4 weeks. At 4 weeks, they'll come out the boot and start physiotherapy. And at that stage, I let them do low impact exercise, like an exercise bike, cross train, and swim.
So this is for ZX or for all the calcaneal osteotomy, you put them in
Uh,
for 4 weeks.
yeah, for both. So I do the same protocol for ZADAC and for my calcaneal slide osteotomies.
Okay. Another question is, do you do so? Is that ZX is your first line of treatment for insertional Achilles tendinopathy if you operate on them?
Correct. And the reason for that, I used to do the open takedown procedure, and occasionally you'll see a patient with the open takedown procedure where they haven't got better. And in that situation, there's not much salvage available. And so I now do all of them with ZADAC, and luckily I haven't had to revise one yet. But if they don't get better, then my thoughts is that I can do the takedown procedures as salvage if required, and I don't remove the spurs as part of my ZADAC procedure.
Just a question. I'm just thinking, do you then ever do FHL tendon transfer? Does it depend how degenerate the Achilles tendon is, or do you even in degenerate tendons you would do ZX first and then see?
Correct. Correct. I don't do an FHL tendon transfer because I, for my point of view, I think FHL is really to add muscle rather than affecting the tendon. And I think with insertional tendinopathy, the problem is not weakness, but pain at the insertion. So I don't normally do an FHL transfer. I know when I was doing my fellowship in the States, they used to think that diseased tendon was the source of pain. They'll cut a big segment of Achilles tendon out, and so they do a FHL transfer to give them more power. But I don't believe the diseased tendon is a source of pain, so I don't actually resect the tendon, so I don't do an FHL transfer as part of this procedure.
Okay, thank you. There's another question about Achilles debridement using MIS techniques. Do you ever do that?
I haven't done that thus far because I do the ZADAC procedure. And I guess if I weren't doing the ZADAC procedure, then I'll probably do a takedown and I may do it as an NIS procedure to do a takedown and reattachment. But because the ZADAC addresses that pain, I don't do it as a combined procedure. And I would maybe consider it if I have a failed ZADAC and I have to do a revision with a takedown procedure.
So for a failed ZX, you would consider an open procedure, obviously. And what would you do? You'll just do what we do and in an open procedure.
Oh, yeah. In a revision procedure, if I had to do one, I'll take out the two calcaneal screws and I'll do a takedown of the Achilles, remove the spurs and reattach the tendon slightly anteriorly and superiorly, like I would do with like I would previously have done with an open takedown. And I may do it open, I may do it MIS.
Thank you. Peter, we'll give you some rest now. We'll come to Robbie. Robbie, there's a question. Do you treat any of your lateral ligament conservatively?
I treat all of my lateral ligaments conservatively at first. So I've never done an acute lateral ligament repair. So all patients who come to see me with ligament injuries, will go through a period of physiotherapy. That'll be at least 8 to 12 weeks. You know, if by 12 weeks they're not having improvements and they're not making progress towards getting back to what they want to do, we'll have a discussion about surgery if they've got ligament injuries. I think I used to be more conservative. I used to wait for 6 months, but I found that after a few months, if patients are not seeing improvements in physio, they're unlikely to then get better. So I'll treat them all conservatively first, and then I will. But I've got a low threshold for operating. If they're not getting better, I'll fix them.
Can I just add on to that? Is there any age limit? Would you consider no age? Age is no bar.
No age limit.
You'll do an 80-year-old?
I've had patients in their late 70s, lady who was playing a lot of golf, and she wanted to go on a Japanese golf tour. She couldn't go because she's unstable. I remember this one clearly as one of the first older patients I did. I didn't want to do it because I was building my series. I thought it might, not have the appropriate results. But then I felt that she had pure instability, no arthritis. I repaired her. She got back to activity. So now, I mean, if the older they are, the more I consider other things. Like I'll be more likely to go conservative in somebody in their 70s. But if you've got somebody that's 80, that's active, they're walking their dog a lot, and they've had a bad sprain of late, suddenly become unstable, they're also a candidate for a ligament repair in my hands.
Technical question. How many portals do you use for lateral?
Yeah, so that's from Kalpesh. Really interesting question. When I learned this, it was a 3-portal technique, and the repair was done using a suture passing. It was based on the guy called Masao Takao from Japan. He used to use a needle, put a needle in and twist the needle to try and catch the ligament. Really complicated. But as the company has developed better technology, we have these jaw-assisted devices. The Arthrex make one called Scorpion. Smith & Nephew have one called the First Pass. They make it much more easy to, like, with a grip to grab the ligament. I found it was much easier for me just to use my more central medial portal, my lateral portal. So I've always done it with 2 portals. The only time I use 3 portals is if I do an augmentation, because although I can reach the neck of the underside of the talus from the lateral portal, you can't get 90 degrees to it, and you can't easily get a subcutaneous suture tape augmentation. That's when I'll use 3 portals. We're currently writing a paper. My registrar, Ms. Newton, is writing it between 2 and 3 portals. We're going to look at about 30 or 40 cases of each to see, and I don't think there'll be any difference. I think it'll be exactly the same. So I don't think you need to make a 3rd portal if you have the technology that's available to all of us.
Thank you. Donatus is asking you, what do you do in recurrence after arthroscopic?
Yeah, so in recurrence,
do you have any recurrence? Have you seen any recurrence?
Yeah. So I've done one. I've done one recurrent case, and that was a guy. He was a young basketball player, and he was playing basketball. He had another bad injury. I tried to treat him conservatively. There's that thing where you overtreat other people's complications, you undertreat your own. So I gave him a bit of time. I was hoping he would just get better, but he was clearly unstable again. And then when I went into his ankle, the ligament had torn right off. The anchor was visible. It was still there. I managed to actually unscrew that anchor and take it out, but the ligament had pulled out of it. So in that case, I re-repaired it, used the same hole, and then I augmented the suture tape augmentation arthroscopically. So, I felt that he was at high risk of multiple injuries, and I wanted a bit more stability. So then in those cases, I will do augmentation. In the rare times I've had to go back and do a revision.
Okay.
I think, Maneesh, could I just add something with that? I think
Yeah.
in terms of the previous question about the MRI scan, I do find that with the MRI scan, sometimes it's hard to tell how strong the ligament is. So sometimes the MRIs may show it looks very attenuated, but when you go in there, the ligament tissue is actually not that bad. But sometimes you go in there, especially in a recurrent situation, the tissue may be a bit crappy. And so I think in that situation, as Robbie mentioned earlier, you have to be ready to do an augmentation in that situation where the tissue is very attenuated from recurrent injury, and you have to give them a little bit more support. So I think in this situation, when you're doing these cases, I think you have to have the brace available to be able to do the augmentation if required, just based on arthroscopically what the tissue is like. Because not all cases whereby Robbie can pull the suture and lift it up, because occasionally they can be very attenuated.
Yeah, no, I
Uh,
agree with you. I've seen a couple of cases where MRI scan has been completely normal, but when you do subject testing, stress X-rays, the whole ankle moves. So no, thank you for coming. Actually, question I would like to ask you both. I mean, I just want to know, open lateral ligament reconstruction, the incision is not that big. We can do arthroscopic. What's the main difference? Yeah, functional results are good. Complication wise, I'm not sure if there is any difference. So, is there any superiority of the arthroscopic procedure over an open brostrom?
so for me, there was two things. So when I started, I was always trained to scope the ankle before doing the brostrum.
Mhm. Mhm.
And I'm like, I'm quite good at arthroscopy now, but I wasn't very good when I started. So it took me a long time, even just to do an assessment. And then the ligaments to all be washed out. I found the repair quite challenging in that wet situation. One of
Mm.
the reasons I started doing it arthroscopically. And now once you get good at arthroscopic ligaments, it's a very, very quick procedure. Very, very quick. My raw video time on average is about 14 minutes now. That's not the case when I started. So if you think of an open repair, yeah, there's the incision, there's the infection risk. That tissue at the base of the fibula is kind of soft skin, and you do get some wound problems. It definitely takes longer, and usually you'll use a lot more hardware and anchors. You know, by the time you do 2 or 3 anchors and tie knots, I think it's quite a lot. So this, though, a single anchor technique, it takes a very short period of time, and the results are good. So, and you find that you and the patients are more willing to deal with more instability. There's a question here about subjective instability from Zain Abedin, and I think that subjective instability to me is probably on this sphere of micro instability. So, you know, people are either have some problems or they don't. And I don't think people like, I'm not sure how many people have psychological ankle instability. I suspect a lot of that is they don't have CFL mechanical instability, but they do have a weak ATFL. They are not confident in that ankle. I think that's what we used to call subjective. We now, a lot of us consider that's micro instability, and it is actually a lesion that can be improved.
Yeah, and certainly in my situation, I think if you do an open reconstruction, they do have more pain and swelling post-surgery. And so I think the when you do an arthroscopic reconstruction, they have way less swelling and they have less pain. But even if you do an arthroscopic reconstruction, I find that you do have to get them going early. Otherwise, they can get stiff with loss of dorsiflexion range. So after 2 weeks, I do get them to start doing dorsiflexion stretches to avoid stiffness. And there's a question about the CFL. I think when you do an all-inside reconstruction, looking at the sections from Mickey Damal, there's a connection between the CFL and the inferior ATFL. And so by doing the all-inside technique, by pushing the ATFL in, you lift and tension CFL, and that addresses the CFL instability at the same time. And that's the theory behind it.
Thank you very much. Peter, Kalpesh has asked you, I think you might have already answered, but I'll just repeat. You're talking about the source of pain in insertional Achilles tendinopathy. So if it is not the tendon, what is the source of pain?
I think that's a very good question. I don't think anyone's got an answer for that. Because I think if you think the Achilles tendon is a source of pain, then you have to cut the tendon out, which I've never done. And I have seen it done when I was doing my fellowship. It was a long time ago, 1998. And so I think for me, the source of pain is probably the tension of the tendon inserting in the calcaneus. And I don't know why they get pain, because some patients with insertional tendinopathy don't have pain. And why that is, I don't know. But I think that probably the pain isn't in the tendon itself. But a good question. I don't think we know at the moment.
And I think that's an interesting concept, right? Because when I did open Achilles debridement, I was like picked up the speed bridge technique, and it was great because you just remove the whole Achilles, and you take all the calcification out, you take all the haglins off, and you repair it back on as an open speed bridge type technique. And the problem with that was you did get weakness, so occasionally you'd have to go back and do something about the weakness, which was like an FHL. But with the Zadex, because you're leaving that complete Achilles with all of its insertion intact, and you're actually shortening it, so giving it a bit better leverage. You don't weakness isn't really an issue after a Zadex, so it's not one where you have to consider an FHL for power, unlike if you do a open debridement. I see Richard's asked a question about fixing the lateral ligament SED. That's a good point. And I haven't had a SED of late to consider that in, but it's definitely going to be the same situation, isn't it? Where the medial tibia will have vertically sheared. And to get to that position, something we've had to go on, which would be the lateral ligaments. And potentially, they're not common injuries. They're generally treated through the trauma system. So if those patients go on to develop lateral instability afterwards, they'll probably go somewhere else, and they're not common. So we probably don't know if that's the case. But if you scope the ankle to clear out the hematomas and to check your reduction, you'll probably find the lateral ligaments are gone. It would be quite straightforward to repair them at the same time. Same caveats, you got to get them moving quickly because arthrofibrosis and stiffness would be a risk.
Thank you. I'm just going to end this by asking a couple of technical questions to both Robbie and Peter. So Robbie first, Peter first. Peter, you discussed the superior migration after calcaneal osteotomy, and you said that if you do proximal medial gastrocnemius release, that reduces the chance. Is that correct? Do you do it all the time then? And
It depends on the amount of tightness. So if they are quite tight, and so if I do a progressive collapsing flat foot deformity, I generally start off with the gastroc release, then I do the calcaneal osteotomy. I'm a fan of arthroresis screw. I put in the arthroresis screw, then I do the medial surgery because I do all my lateral side first. And so that's my routine of doing it. If you've got mild tightness, then you'll find that when you do the calcaneal osteotomy, the fragment will slide up slightly, and they might not be so tight afterwards. You might not need to do a gastroc release. But if they're very tight, if you don't do a gastric release first, then they will slide up quite a lot.
Yeah. And what's your technique of proximal medial gastrocnemius? Do you do proximally or do you stairs?
Yeah, so I do proximally, just about 2 centimeters below the knee. And I do that with the patient with the leg externally rotated. I just release it proximally to reduce weakness. If they're a little bit more tight, I'll do Australia. But my tendency is not to do Australia unless they're more tight, because I find that they do get calf weakness post-surgery.
Thank you.
So I can just add something to that. So
yeah,
I do the same as Peter, probably because he trained me. But I don't do a gastroc release when I do a cable varus type thing, when I'm doing a valgazing osteotomy. So I want to maintain the tension, and sometimes that can also slide. That can also dorsalize, which is good because you want to flatten the foot a little bit. But I had one patient who then developed posterior impingement, so I'll let it slide up. I'll fix it. I'll use the burr just to flatten it out now in the lateralizing calcaneal osteotomies. Because if you get a sharp bump there, I've had one that was painful. I'll show that at BOFAS.
In the same setting, or if they become symptomatic afterwards?
Same. Well, now that I know it's a risk, it takes a few minutes. Now that I know that's a risk, I'll show it at BOFAS.
Yeah, I think in that situation, I wonder with Robbie's case, like in the one that I showed, that's high risk if you place the osteotomy more anterior. And so in that situation, I'll probably place the osteotomy slightly posterior. And that's why I like it at the calcaneal tuberosity, just anterior to that. Because you place it more anteriorly, it slides up, then sort of like the case I show, you can have risk of posterior impingement from that displaced fragment.
I was going to ask Robbie, I don't know if we have time. Very quickly, Robbie, what about deep deltoid then?
Deep deltoid is a different beast. It's a very, very strong ligament, as we know, but it's a very short ligament. So I think if you ever see one, it's impossible to actually repair it. It doesn't have any length to it for repair. So anytime you're doing anything to deep deltoid, it's going to be a reconstruction, whether that's a allograft or whether it's a tape augmentation. And I think you're quite high risk of over tightening that structure and overloading your medial side. I think that's more of a question for ankle arthroplasty surgeons. I think they're the only ones I know who have good experience of regularly doing sort of deep deltoid reconstructive procedures, because I don't think it's necessary. I think by repairing the the superficial deltoid.
I just wanted to know if you have any magic technique.
No.
No.
I don't think you should, do a reconstruction of it without really being careful. I think if you just percutaneously reconstruct it, you'll find that suddenly they're in varus, they're overloading, they'll get arthritis. I'm pretty careful about
that. There's a question about the burr that they are not available in UK. Have you seen that question, Peter?
Yes. Thanks, Tom, for the question. And so you can use it. So basically, the technique that Kaplan et al. Described is basically, yes, you pulverize, so use the burr and cut in segments, but that is still challenging. And I think the big burrs will become available, I think, probably within the next year or so.
Fantastic. Just last question. We won't take any in interest of time. Peter, what's the question? What's the reason for first cutting the near cortex and then the far cortex?
Because it's easier. And so because you create a tunnel, so it's much easier to cut up than it is to start the downward one, for me anyway.
Fantastic. And
it.
Robbie, yes, Robbie.
The last thing about that is the calcaneus is quite wide. If the smooth part of your burr goes into the calc while you're cutting, it gets trapped and it heats up a lot. We see that in the lab a lot when we're training people. So if you do the near cortices first and then the far cortices, it's always the spinning parts that are in the bone, and then you've got a lot less chance of non-unions and burning the bone. So that'd be another reason to always do a large bone like that in quadrants.
Fantastic. Look, the fact that almost 95% people are still here is great. Obviously people are very well engaged in the discussion, and both of you have taught us a lot of things. And as you've seen, people are willing to come and travel. Maybe Australia might be difficult, but Robbie certainly people will come and see you in London. But somebody, Peter, might come. I might consider going to Australia, as you know. Thank you once again for your time, and thank you, listeners. And as I said, just give us the feedback and maybe plans for the next Master Techniques, which we'll do sometime, maybe February, March next year. And of those who are coming to BOFAS, I'll